Hello dear students, in this video we are going to continue with the GI secretion. In the previous video we saw about the salivary secretion. In today's video we will be discussing about the gastric secretion. So I would like to make this as a two different section of video. The first will be the gastric secretion, how the HCl is secreted and all those aspects will be discussed. In the next video I will be discussing about the peptic ulcer disease and some other syndromes which are relevant to the gastric acid secretion, that is Zollinger-Ellison syndrome and gastroesophageal reflux disease. So first, today this video will be at the discussion of the gastric secretions. So let's get into the video. Gastrics does a lot of secretions, but among that the HCl is of most important. So we'll be discussing in detail about the HCl secretion. So the gastric secretion, it is around 1.5 to 2.5 liters per day. And like the phases of the salivary secretion also, the gastric secretion also happens at various phases, we can say. The first one being the cephalic phase. In the cephalic phase itself, just look at it like when we are thinking about the food or just seeing at the food, at that time saliva was secreted. But at the same time, the gastric secretion also will start to happen because basically it is trying to get ready itself before the meal arrives into the stomach. So that is the cephalic phase, the sight of the food, smell of the food or the thought of the food. All of them will stimulate the vagal nuclei, the dorsal vagal nuclei, and it will release two things. One is the GRP, that is nothing but the gastrin related peptide, releasing peptide also we can say, gastrin releasing peptide. Another one is ACH. Both of them will increase the acid secretion. So in the cephalic phase itself, the acid will start to secrete. Next, maximal secretion happens in the gastric phase. What is this phase? When the food reaches the stomach, the maximum amount of HCl is secreted, that is around 60 to 70%, and followed by a little bit of amount in the intestinal phase wherein 10 to 15% is secreted. How this gastric phase maximal secretion is happening? It happens through the vagovagal reflex. So whenever there is a stretch in the stomach, the vagal nerve endings, they will form the afferent, that is the vagus, and the efferent also comes via the vagus to stimulate the acid secretion. That's why it is called as vagovagal stimulus. So both here the afferent is also vagus and efferent is also coming via the vagus. So these are the three phases of gastric secretion. Next, coming to the constituents of gastric secretion. The gastric mucosa has three different parts. The stomach has three different parts. The cardiac end, then the fundus and the body, then the antrum and the pyloric region. Both the cardiac end, antrum and pyloric region, they will be highly secreting the mucus and the bicarbonate. To protect the GIT, these two areas will be highly secreting the mucus secretion, so that when HCl is being secreted, it has to protect the GI stomach itself. To protect that, the mucus and bicarbonate is secreted. Next, the fundus and the body region, there are multiple cells, as you can see from this diagram. There are multiple cells which are located and each of them are going to do its function. So first one, the uppermost layer is the mucus layer. So first, the GI should protect itself from the HCl that is being secreted. So the beauty of it is, the mucus layer will form a layer like this throughout the GI membrane. And wherever the gastric pits or the gastric acid is being secreted, that will be secreted above this layer because HCl is highly acidic. So we do not want it to damage the GI. So the mucus layer is there and the secretion whichever is coming, it is coming above this layer. That is the beauty of the nature. Second thing is, this is secreted by the surface mucus cells, which in turn secretes mucus, trefoil peptides and bicarbonate to protect it. Next comes the mucus neck cells, which is also acting like a stem cell for the regeneration because the GI mucosa, it is continuously getting degraded, so they will help in regeneration. Next comes the most important cell, the parietal cell. It is also called as oxyntic cell. This cell is the one which is going to secrete the most important secretions of the gastric juice, that is the HCl, the acid, plus it secretes one another important factor which is called intrinsic factor, which is important for the reabsorption of vitamin B12. Next, below that we have the ECL like cells which are going to secrete the histamine. What is this ECL? Is enterochromaffin like cell. Enterochromaffin like cells. And below that we have the chief cells, which is going to produce the pepsinogen, as well as they also produce the gastric lipase. Gastric lipase. And below that again there are some amount of stem cells which will migrate to the above region as and when the cell is being shed, the epithelium is being shed. So here the most important cell is the parietal cell, which is going to produce the HCl as well as the intrinsic factor. Next is the chief cell, which is going to produce the pepsinogen or gastric lipase. So this is how the fundus and body is secreting. Now let's see how this acid secretion is being regulated. What are the elements which will regulate it, when they will be secreted more, or who will inhibit it? It is divided into neural regulation, wherein the nervous system itself will regulate it, just like the vagovagal reflex we saw. Then humoral reflexes, wherein the hormones involved, they will regulate it. And the third one is luminal factors. Depending upon the nature of the food, the luminal factors are going to act upon and they are going to control the regulation. So first, coming to the neural regulation. As and when the food comes in, the enteric nervous system gets activated. All of us know, because in the GI motility test I told you, the stretch will help to sense it. So the Meesner's plexus will also get stimulated. And what is the function of the Meesner's plexus? They will increase the blood flow, thereby increasing the secretion. So this is nothing but the vagovagal reflex. Where there is a stretch induced secretion, it is completely under the neural regulation. Then coming to the humoral, which is again very important. The humoral regulation is done by multiple hormones, I would say. So the gastrin is produced by the G cells and they are produced by the antrum of the stomach. Next, ECL-like cells, the histamine, they will also be produced, and acetylcholine through the vagal impulse. All these three hormones, they are going to increase the gastric secretion. They are like super close friends. So here when gastrin, histamine and acetylcholine is available, they are not going to be 1 plus 1 plus 1 is equal to 3. They are going to be supra-additive. This effect is called supra-additive. That is, when one is available and the second one comes in, he will stimulate the other person also. So that's why this effect is called supra-additive effect. So remember all these three hormones, gastrin, histamine, acetylcholine. They are the most powerful stimulators of the gastric acid secretion. In turn, the opposite hormone which is going to decrease the gastric secretion is the somatostatin, which is produced by the D cells. So gastrin from G cells, the histamine from the ECL cells. Next, coming to the luminal factors. So when the food comes in, most of the time the peptides and the amino acids, they are a strong stimulators of gastrin, thereby decreasing the acid. So whenever there is alkalinity, that is, there is an increase in pH, again that also will stimulate the G cells, which will increase the HCl. And whichever HCl has increased, what they do is they go and feedbackly inhibit through a negative feedback mechanism of the G cells. Suppose more and more HCl is produced. What they will do? They will go back and inhibit the G cells, thereby saying it that there is already too much of gastric juice, don't secrete much. So this is a negative feedback type of mechanism. So these are the luminal factors which are influencing. So we saw the neural regulation, hormonal regulation, then the luminal factors. Now coming to the molecular mechanism of how the acid is secreted. Till now we were just discussing the HCl is secreted, but here we are going to analyze the in-depth mechanism of how the acid is being secreted. Why this is important is because the majority of the drug that we are going to give whenever there is a hypersecretion of the acid depends on these pathways. So let's get into this. So first, inside the parietal cell, I already told you this cell is nothing but the parietal cell is the one which is secreting it. Here there will be a combination of H2O plus CO2. Both of them will be derived from the blood. So they will combine to form H2CO3. This is one universal reaction in physiology. You will study it in a lot of places. Then further they will split into H plus, then bicarbonate, HCO3 minus. Then let's see what happens to this bicarbonate. This bicarbonate will go to the basolateral side. Here first I have to understand inside the parietal cell, wherever the lumen is present, suppose you can see here I have marked this area with some epithelial cells. So this is called as luminal side, where the food is present, luminal side, or it is also called as apical side. And whichever side is closer to the blood vessel, here we have the blood vessel, whichever side is closer towards the blood vessel side, You can remember it. Towards the blood, it is basolateral side. Now, whatever bicarbonate is produced, this will enter into the blood. Here bicarbonate will enter, and many times we keep on seeing that the bicarbonate generally gets exchanged for chloride. So the chloride goes in. So this particular exchanger is called as anion exchanger of the type 1. Why it is called anion exchanger? Because it is sending out one anion and bringing in another chloride. Okay. So because of this, the bicarbonate comes into the blood. So after you eat, what will happen to the blood side? The blood side will have high alkalinity, that is called as postprandial. After food, there is an alkaline tide. So this happens after you intake the food. Then the chloride which enters into the system, it is slowly sent to the apical side with the help of a channel, that is chloride channel. This channel, so we have got the chloride inside. Now we have already formed H plus and bicarbonate. So this H plus can go in an independent channel, that is the H plus ATPase channel, or it can also go to the apical side or the luminal side with an exchanger, that is H plus K plus ATPase exchanger. H plus K plus channel. So this channel is H plus K plus ATPase. And there is another channel which is going to send out this potassium again outside. So because of that gradient, again potassium will come inside. So when potassium is going outside, the gradient is created to bring it inside. In the meanwhile, the H plus is transported. Then we have to understand one important channel which is going to supply a lot of energy to most of the channels, that is the sodium potassium ATPase channel, which is bringing in the more and more potassium, because of which the potassium is thrown into the luminal side, and for the potassium exchange, the H plus moves in. So this is the channel which is driving the force, I would say, that is the sodium potassium ATPase channel. So let's recap a bit. In the apical side, we have H plus ATPase, H plus K plus exchanger, and the chloride channels. So inside, where there is formation of H plus and bicarbonate, bicarbonate comes to the basolateral side in exchange for chloride, which is sent out, and the H plus is also secreted. Now we have H plus as well as the chloride. They are going to form the HCl. That's how the acid is being formed. So a recap of it: H plus channel and H plus ATPase. These are called as proton pump because they are pumping out the protons H plus, and the chloride channels are present. And in the basolateral side, we have the anion exchanger. And the beauty of it is all this acid is secreted above the mucus layer. Like a jet, like a spray, it will come and spread above the mucus layer, thereby keeping the GI intact, because HCl is highly acidic. Then what are the stimuli for this H plus ATPase channel? Already we know there are three people who are going to increase this H plus K plus ATPase, that is a gastrin, acetylcholine, and the histamine. So there is a receptor, M3 receptor, muscarinic type of receptor, through which the acetylcholine will act. Then there is a receptor called CCK B. CCK is cholecystokinin, but the receptor type is B, because on the A receptor, CCK type A is also there, through which the cholecystokinin will come into action. But it is looking very similar to that receptor, so they have named it CCK B. So who is going to act on it? Secretin. Then there is another receptor called H2 receptor, through which histamine is going to come and act. And I already told you all three of them are friends. And the apical channel is the hydrogen potassium ATPase exchanger. The M3 and the H plus, both of them will increase the intracellular calcium levels, thereby stimulating this channel, whereas CCKB will increase the cyclic AMP pathway, the second messenger pathway, through which this channel will get activated. Now, why we have to know all this data is because the drugs which have been designed to reduce the acid secretion are based on these fundamentals. So, if I am able to block this H2 receptor somehow, will the acid secretion come down? Obviously, yes. So, to a patient where the acid secretion is not that severe, or he is coming to the clinics for the first time, or in those patients, we can try out this drug that is called as ranitidine. Ranitidine is nothing but a H2 receptor blocker. Why I am saying for severe conditions we cannot use it? Because it is going to block only one arm of the secretion. ACH and secretin will be still acting on it and producing the acid. So for a mild symptoms, this is very well good enough, because I should not suppress too much of acidity also, because HCl has its own benefits also. Next, if I attack this area, this is called as proton pump. So I can attack this area also. Those drugs are called as proton pump inhibitors. You can drop it in the comment section. What are the group of drugs which are acting at this area? I'll be happy to look at your answers. So that is one more group of drug, proton pump, we are going to inhibit. And there are some group of drugs, if the HCl is already secreted, I just want to decrease its effect, then we can give them antacids. So for the H plus which is already secreted, antacid will work. For prevention from getting into more secretion, ranitidine will work, and more effectively the proton pump inhibitors are going to work. So this is how the drugs on which the HCl has to be suppressed works on it. So let's see the functions of HCl. That's why I said it's not good to stop all the acid also. So do not directly jump in and prescribe proton pump inhibitor for all the patients. So it is a strong acid. So whatever intake we are taking, it will help to break down the food. And most of the time, the things that we eat outside have a lot of bacteria that also will be killed. Then it will help to activate the pepsin. And ion absorption also it helps, wherein it converts Fe3 plus the ferric into a ferrous state. And ferrous state is the one which can be reabsorbed in the GIT. So this conversion is also done by HCl. And it also helps in indirect production of bile and pancreatic juices. How when this acid enters the intestine will get a signal, there is so much of acid. So they have to reduce it. So they will produce two hormones. One is the CCK and secretin. These hormones will help to enhance the bile secretion and pancreatic secretion. And pancreatic secretion has a lot of bicarbonate which will neutralize this H plus which has entered into the intestinal area. So that is the importance of this HCl. So strong acid, it kills the bacteria. That is one of its most important function. And there are factors which are increasing the acid, which I already told you. The acid is on one side, and we have the barriers or the protectors on the other side, which are the bicarbonate, the mucus, some of the growth factors, trefoil peptides, and prostaglandins. All of them are fighting against this acid so that to prevent the mucosa. But if the acid secretion goes beyond a certain level, more than the barriers, then there will be disruption of the mucosa, finally leading on to peptic ulcer disease. So there is always a fine balance between these two. If acid takes an upper hand, then there will be a peptic ulcer disease. So recording the disorders, we will discuss in the next video. I'll be posting these videos simultaneously, so it will be available in the channel. Make sure to watch both of them. Thank you for watching. If you have any further doubts, kindly drop it in the comment section. Thank you so much.